So let's talk about the clinical forms, okay? The clinical forms of pre-eclampsia. Clinical forms of pre-eclampsia. So the first one, okay, we are going to use some parameters to do that, okay? It's going to be dependent on the following parameters. So the parameters, one, we can talk about the blood pressure. Two, we will think of the grade of proteinuria. Three, presence of signs and symptoms. We'll talk about that very soon. Then four, presence of what? Seizures. Are seizures present? So these are the four parameters that we are going to take into consideration. The four parameters. Okay? The four parameters. Now, before we move ahead, let's talk about the signs and symptoms. Okay, the signs and symptoms. Okay. When we say signs and symptoms, the moment those symptoms and signs are present, it tells you that eclampsia is imminent. When you say something is imminent, it's in sight. If nothing is done immediately, if there is no timely intervention, you are going to have seizures happening. Are you getting that? So the signs and symptoms, the presence, they tend to indicate that eclampsia is imminent. Are you getting that? So let's talk about those signs and symptoms before we move ahead. So we will talk about the symptoms, signs. So anyway, if you are in the obstetric department, you are talking about symptoms and signs. These are the things you'll be thinking of, okay? So the first one, for the symptoms, we can talk about severe frontal headaches. You can also think of vomiting. And do you know why this will happen? Do you know why? Who knows why? Because if you go into the world of physics again, or in the world of biophysics, you realize that the intracranial pressure as defined or explained by Monroe and Kelly, that the intracranial pressure is going to be defined by the following constituent. They made mention of what? The CSF. They made mention of what? The pressure in the veins, that's the vascular veins and arteries. And also, they also made mention of what? So you have, and also the tissues in the brain mass, okay? And we can also take into consideration that basically the brain mass, okay? We are thinking of the CSF. We are also thinking of what? The blood flowing and the brain mass. And they say that one of the things that regulates, okay, homeostasis in the intracranial pressure will be what? The CSF. That's why if you watch, if the CSF is not draining or is not undergoing resorption by the subarachnoid granulation of villi, it will tend to collect and it will cause what? The ventricles to what? Become large, ventriculomegaly, and the intracranial pressure will increase. Are we getting that? And if you look at meningitis, okay, why do you think, or if you look at stroke, hemorrhagic stroke, why do you think that the intracranial pressure will increase? It's because the blood, is it draining? It is not. Is it draining? It is not. There's going to be pressure effect on the drainage pathway, okay, of the what? The blood vessels. And if that happens, it's one of the components that contribute to what? The intracranial pressure. So if that is happening, the intracranial pressure will increase, and once intracranial pressure increases, you will start seeing what? Symptoms and signs. And one of them, vomiting, even headache. So all the symptoms and signs that we are going to talk about, especially the symptoms, they are going to be as a result of what? Increased intracranial pressure. Why are we saying that? Because again, pay attention. We said that in pre-eclampsia, the pathophysiology, there's incomplete, right? We said incomplete invasion by the cytotrophoblast, meaning that the spiral arteries are still intact, and these will affect every vessel That's why we say it's a multi-systemic disease. If you go into the brain, as I said, I use one of the mechanisms by saying immunological injuries, meaning that if there's an injury to the endothelium of the blood vessels in the brain, there will be what? Platelet activation and aggregation onto the site of the injury, narrowing the lumen of what? The blood vessels. The vascular resistance increases, the pressure what? Increases, and that pressure will contribute to what? An increase in the intracranial pressure. Hence, the following symptoms will be seen: severe frontal headaches. There will be what? Vomiting. The next one will be visual disturbances. They will have that, visual disturbances. Visual disturbances such as they will be seeing tutu, diplopia. There will be flashes of light, as if they are seeing a ghost. Not the ghost per se, but flashes of light. They will also have what we call scotomata. Scotomata. What is scotomata? Blurred vision as well. Yes. What is scotomata? Yes. Excellent. So it refers to a blind spot in an otherwise normal visual field. In an otherwise normal field of what? Vision, or normal visual field. That's scotomata. So they will have severe frontal headaches, vomiting, visual disturbances such as diplopia, flashes of light, blurred vision, scotomata, which refers to a blind spot in an otherwise normal visual field. Then the next one, talk about epigastric pain, which can become what? A right upper quadrant pain. So you go for an exam and they ask you what accounts for right upper quadrant pain in pre-eclampsia. Then you will tell them again that, yes, go ahead, Nafisa. Yes, it will be due to a subcapsular hematoma. And again, it will have to deal with the vessels in the lying under the capsule of the liver, the Gleason's capsule. Meaning that those vessels, once there's an endothelial injury and the blood is not able to flow freely through them, what is going to happen? The blood vessels will start what? Dilating to what? Accommodate the congested vessel. And as they dilate, what happens? They can easily what? Rupture. And when they rupture, the blood will start flowing into the subcapsular space, causing a subcapsular hematoma, stretching further the capsule, irritating the nerves running along the capsule, giving a right upper quadrant pain. So in short, the epigastric, the right upper quadrant pain that we are talking about is going to be as a result of a subcapsular hematoma. Is that clear to you? All right, let's move ahead. Now, for the signs, we'll think of an increase in hypertension, increasing hypertension. The next one, we are going to have increased deep tendon reflexes. With or without ankle clonus. What is clonus? Okay, we'll talk about that very soon. Clonus is more like a repetitive, uncontrolled, okay, rhythmic movement, okay, elicited where? In the ankle, greater than or equal to 3 to 5. Maybe it's greater than 3 to 5, okay, rhythmic movement, uncontrolled. When there's rapid dorsiflexion of the foot. If I say rapid dorsiflexion, if you take this as my foot, okay, and this is the dorsum, this is the sole. If I rapidly dorsiflex, you will see that there will be movement of the foot, okay. If there's uncontrolled rhythmic movement of the foot more than 3 to 5, or basically more than 5, okay, then we can say that is a positive clonus. Positive ankle clonus. It's elicited by what? Rapidly dorsiflexing the foot. Okay, rapid dorsiflexion of the foot produces greater than 5 rhythmic uncontrolled movement of what? The ankle, or uncontrolled movement of the foot, and we call that clonus, anchor clonus, and it will be positive in which of them? Upper motor neuron lesion or lower motor neuron lesion? And second, upper motor neuron lesion. And what is the precipitant for clonus? Normally, I mean, normally we are supposed to have it. We are supposed to have a rhythmic movement, but it should not exceed 5. Are you getting that? And that reflex is elicited when you dorsiflex the foot. You are stretching the fascia of what? The gastrocnemius muscles. Are you getting that? Gastrocnemius muscles. When you create tension on the fascia, yes, that is what is going to precipitate the reaction. But if there is an upper motor neuron lesion, there is going to be loss of control over this reflex, and it will start to what? Go into a state of what? Hyperstimulation. So it will continue to move without any restraint. That's what you are saying. It belongs to what? The upper motor neuron lesions. Exactly. Yes. Then again, there will be liver tenderness, which we already explained that it's resulting from a subcapsular hematoma. And the last one, we are thinking of oliguria. The oliguria, we will say, if that is urine output less than 400 mils per what? 24 hour. Less than 400 mils per 24 hour. So these are the symptoms and signs that we are talking about. I hope that is clear. You go for any examination, or you are working in the labor ward, or you are at the obstetrics emergency, and the patient comes, hypertension, proteinuria, and tells you that she has been having this kind of severe frontal headaches, and in addition to that, paracetamol or any analgesic is not taking it off. Then you are thinking of, okay, you should ask for the other symptoms. Epigastric pain positive, yes. You want to check how much urine has she passed. It's not even up to 200 for the whole day. Then you are thinking of what? The presence of signs and symptoms. It means that eclampsia is imminent. Or we can also call it a severe pre-eclampsia. Therefore, something should be done. When it's imminent, it means that you should take a step. And that will call for what? Immediate delivery. Okay? Okay. We'll have mild pre-eclampsia, or what is currently known as pre-eclampsia with mild features. Preeclampsia with mild features. So for this, the blood pressure. So for the blood pressure, systolic blood pressure would range from 140 to 159 millimeters of what? Mercury. Is that clear? Diastolic blood pressure is going to range from 90 to 109 millimeters of mercury. Here we are not going to go by the JNC7. We are not going to use the Joint National Committee 7th edition. We are not going to use that. Okay. Then we move ahead. Degree of proteinuria, grade of proteinuria. Grade of proteinuria. We will say 1 plus, 2 pluses. And next one, presence of signs and symptoms. No, we are not going to have them. Symptoms and signs. No, they will be what? Absent. And next one, seizures. Are they going to be present? They will be what? Absent. Please, is that clear? Is that clear? Okay. Can we move? The next one, severe preeclampsia or preeclampsia with severe features. Severe preeclampsia or preeclampsia with severe features. Here, we'll say the systolic blood pressure should be greater or equal to 160 millimeters of mercury. and the diastolic blood pressure should be greater or equal to 110 millimeters of mercury. Okay, for this one we'll see on two separate occasions. If I say on two separate occasions, it means that at least 4 to 6 hours apart, or greater or equal to 120 millimeters of mercury on a single occasion. Are we clear? So if the diastolic blood pressure is greater than or equal to 120 millimeters of mercury on a single occasion, you can consider it in the zone of what? Severe preeclampsia. Please again. If the systolic is not up to that level, we know hypertension, you go for the highest limit, the higher one. And you should take note, if any of the parameters are present, you will capture it into the classification of that particular one. So let's say here, systolic blood pressure was 140, diastolic blood pressure is 120. Automatically, it becomes what? Severe preeclampsia. Exactly. Proteinuria, you are going to have greater or equal to 3 pluses. Say proteinuria is greater than or equal to 3 pluses, yes. We are also thinking of what? Severe preeclampsia. Presence of signs and symptoms may or may not be present. May or may not. So it's plus or minus. May be present, may not be present. Plus or minus. It doesn't mean that if a patient comes and she is not having symptoms, it's not severe preeclampsia. It is. If the patient comes and she is having symptoms, yes, it is also severe preeclampsia. Are we getting that? Then seizures, of course, seizures absent. Seizures are not present. The third one, as I said, currently is no longer part of the classification. It's no longer part of the clinical form, but you should know in case of anything, okay? The one that we are going to look at is incorporated into the severe preeclampsia because it has everything the severe preeclampsia has, plus always the symptoms and signs will be present, okay? Can we move? Can we move? So the next one, we have what we call imminent eclampsia, or what we call fulminant preeclampsia. So I said this particular one is no longer currently considered, but it's incorporated into what? The severe preeclampsia. Okay. For this one, yes, it will have everything like the severe preeclampsia. Sometimes the BPs may be variable, the proteinuria may be variable as well, but since it's incorporated into severe preeclampsia, we would let those features also be there, okay? But here, the only thing is that the presence of signs and symptoms is always. So take note that imminent eclampsia is currently the same as what? Severe preeclampsia. Take note of that. So it has been incorporated into what? Severe preeclampsia. So it will have everything like severe preeclampsia, just that the signs and symptoms are always going to be what? Present. Is that clear? And next one, can I clean? Okay, let's hurry up. Please, can we move on? Can we move on? So the next one, which is the last, is what? Eclampsia. 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 So for the eclampsia, yes, we'll still keep the VPs like this, or they may be variable. It's either like this or variable, okay? Proteinuria like this or variable, okay? Presence of signs and symptoms, yes. May be present prior to, and there will be seizures. There will be seizures. Eclampsia doesn't mean eclampsia. Eclampsia will progress from where? Severe pre-eclampsia. So we'll keep it like that. But here we'll say that eclampsia simply is what? Pre-eclampsia with generalized tonic-clonic seizures. Okay? Seizures, or what we call convulsions or fits. And if you say generalized tonic-clonic seizures, Teresa, in febrile convulsions, which type of febrile convulsion will you be thinking of? That is correct. So it's for the simple febrile seizures. That is correct. Simple febrile seizures. That is correct. All right. Please, can we move on? Can we move? Now, the next thing we're talking about is the management. Okay. We'll be managing them. Okay. When we are done with the managing of each of them, we'll move straight and talk about after we manage, we'll talk about the indications for immediate delivery in severe preeclampsia. Then after that, we'll look at the complications of preeclampsia, and that would end the topic. But then we'll have some 30-45 minutes break. When we come back, quickly run through cervical cancer. And that will be it for the day.